ladies and gentlemen and everyone, welcome. We're talking about sexual intimacy after cancer, and it gives me a lot of pleasure to welcome Dr. Isabel White, who's a cancer nurse and a senior accredited psychosexual therapist. In 2010, she established and led the first psychosexual therapy service at the Royal Marsden Hospital in London, and she worked there with cancer patients for 9 years. And now Isabel is with Percy Health, and she's working again as a psychosexual therapist and also Director of Clinical Service Improvement. And Percy Health is the UK's first virtual cancer survivorship clinic. It offers access to a range of multidisciplinary cancer experts across the United Kingdom, including psychosexual therapists. So, big welcome to you, Isabel.
Thanks, Julie.
Before I ask you, what on earth psychosexual therapy is, I certainly did not hear about them when I was a cancer patient 10 years ago. I just talk about the difficulties that many doctors and other cancer clinicians have in talking about sexuality, to even raise it. I think you've done a bit of research on this. What are the three key barriers to clinicians raising sexuality with their cancer patients?
That's such an important question, because I think it really impacts, I suppose, on people's willingness to open up the conversation. I think one of the first things, unfortunately, is embarrassment. So although doctors and nurses and other health professionals talk about personal and intimate things with patients, including, things like their bowel function and their bladder function, there's something about asking people about their sexual well-being and their sexual lives that is actually more challenging than other topics that they might address. So I think that's one of the first barriers. I think the second barrier, and equally important, is that in many cancer centres, there are not established pathways for onward referral. So obviously, if you're going to open up a discussion about sexual recovery or sexual well-being after cancer treatment, if you don't feel that you've got specialists that you can refer on to, and you're not clear about the pathway of management, then again, that's going to block you from opening up the question. And I think the third one, which is perhaps a defensive myth in lots of ways, is to say, well, if the person with cancer thinks it's important, they'll ask me the question first. And actually, when you consider what people with cancer who are being diagnosed and treated are facing, they've got so many things on their minds at that moment. I think it really is our responsibility as clinicians to create that kind of almost that level of permission that this is a legitimate aspect of cancer and cancer treatment impact and your rehabilitation and recovery that you can ask your treatment team about.
And you actually think it is the responsibility of clinicians to raise the topic? Why isn't it good enough if you've got some form of questionnaire or some form of patient-reported outcomes to just put sexual intimacy there and hope someone will tick it?
Typically, and the research backs this up, there's often a significant avoidance amongst patients, again, partly because within the systems that they're being cared for, they don't necessarily always recognise that sexual consequences will happen to them. So they may not actually be aware that it's going to be a problem, again, depending on when you're asking the question or giving them that reported outcome measure. So there's a risk that I guess they may not know that it's impacting on them at the time that they're faced with that. There's also, I think, their inherent embarrassment, particularly if they're faced with clinicians that may be younger than them, young enough to be their own children sometimes. They may say, oh, it's not something I feel that I can ask my doctor or my nurse. And they may not feel that, that's actually a legitimate aspect of their health and recovery to ask a question about. So I think there are many blocks and barriers for patients in terms of them bringing that topic up. So I would certainly say that it is the responsibility of clinicians to raise the topic proactively, much as they do with other aspects of people's recovery. And I think going back to your point about outcome measures, if you have got brief screening instruments or very short, brief outcome measures that are particularly designed for use in clinical settings, they can provide a very useful structure to open up what can otherwise be an awkward conversation. So they can actually be very helpful, but you've got to know the instrument that you've chosen to use, and it needs to be integrated into routine practice.
Look, I want to come now to the sort of services you built at the Royal Marsden Hospital when you established the service, and at the same time get a sense of what is psychosexual therapy and what is what's often called in the literature biomedical treatment. So what were the services you offered in a nutshell, and can you explain those terms?
Absolutely. I'll start off with the services that were established at the Marsden. So I think the first thing to say was actually the establishment of this service actually came from a patient initiative. So it was patients who were saying, we don't feel the current services are actually meeting our needs. We feel that these are unmet aspects of our recovery. Could we look at establishing a service? So the chief nurse at that time made contact with me because we were already professional colleagues and said, can we look at establishing a service within the adult psychological support service at the Marsden? So we went ahead and established that service, and essentially it meant identifying a cancer qualified person, so it happened to be a nurse, with additional psychosexual therapy training. And my first job, I guess, when I was appointed to that role, was to actually reach out to medical, nursing and allied health professional colleagues and to find out what they felt were the blocks and barriers to being able to offer support really and information and interventions around the sexual consequences of treatment. So we started off by doing in-depth surveys of what they knew and what they found challenging or difficult, and then went on to, I suppose, base the development of the service around that feedback. So essentially, it was a single psychosexual therapist, but working in partnership with the clinical settings where the level of sexual disruption was already identified to be significant. So I worked closely with the breast unit, the urology unit, and the lower gastrointestinal unit.
We have limited time, and I know there will be patients or family members watching this who want to say, well, look, if I can find one of these psychosexual therapists, how on earth will they help me? And I guess as a head and neck cancer patient, as I was with throat cancer caused by the human papillomavirus, so a sexually transmitted virus, I'm feeling, do only people who have cancers on the breast or the groin and pelvic area get help? Don't they know that the head, the mouth, the heart, the mind, feelings are sexual too? So if you could just get concise but nitty-gritty, how do you actually help people? And are head and neck cancer patients getting an equal service to other sorts of cancer patients?
I think if you look at psychosexual therapy and its focus, you're really looking at 3 dimensions of impact. You're looking at what are the physical effects of the cancer or the cancer treatment that might be impacting that person's sexual function and sexual well-being and sexual identity. You're looking at what are their emotional responses to those changes, whether those changes are permanent or temporary. And then you're also looking at, if they're in a current relationship, what are the relational impacts on the dynamics for that couple? And if they're not in a current relationship, you're looking at what facets of going forward in trying to establish a new relationship will need support and development with that person. And so if you look at those 3 dimensions, as you rightly point out, Julie, those are dimensions that definitely impact on people affected by head and neck cancer. But sadly, because within health services, we're very focused only on the first, which is physical and functional, people will tend to then focus mainly on parts of the body that are more overtly associated with sexual function, particularly intercourse. And so that's why they focus predominantly on pelvic cancers and on breast cancer. But it doesn't take a mastermind to, as you rightly point out, to say, you know, if you're looking at the head and neck region, not only is it a major impact on body image and what will then turn into, if you like, your sexual confidence around communication, around kissing, around giving oral sex, for example. So really, really important that people with head and neck cancer are offered the opportunity to access these services. But I would say that the level of awareness in head and neck services is still lower than in perhaps some other clinical services.
I know you've had the opportunity, Isabel, to visit two major cancer centres that are offering psychotherapeutic services for cancer patients in the States, Dana-Farber Cancer Institute in Boston and also Memorial Sloan Kettering Cancer Centre in New York. And there's a number of cancer centres in the United Kingdom, the Royal Marsden in London, the Christie in Manchester, University College Hospital in London, and Guy's and St Thomas Hospital in London, and no doubt others. For professionals watching this, for families and patients watching this, what are those services doing well? Just in a nutshell, 2 or 3 key things. And is anyone doing well with head and neck?
I think to answer your second point first, I think there's probably an underrepresentation of people with head and neck cancer accessing these services. And I think it's really about awareness raising and trying to encourage clinicians within oncology services to actually consider not just a narrow kind of functional focus on being able to re-establish sexual intercourse, but actually looking at how cancer and cancer treatments impact on the whole person. And that means that you really need to offer in a, if you like, a sexual health or a sexual well-being service in oncology, what we would refer to as a integrated biopsychosocial approach. So going back to what I said earlier, you're looking at physical functional corrections or reconstructive options that actually help improve function, or indeed surgeries that perhaps limit the impact in the first instance on sexual function. But you're also importantly looking at how do I support that person emotionally in terms of their adjustment to the changes in function which may be permanent? How do I help people, for example, who are experiencing difficulties in terms of adjustment to changed appearance? And what does that mean for them in the roles that they have in their lives? And then also importantly, how can we work with couples? So working in partnership with couples to look at the dynamics that have happened as a result of the cancer experience and actually enabling them to move forward. And that's what these other services are doing well, where those services exist.
That integration, and I just want to make it clear to our viewers and cancer team members watching, of course, dealing with erectile dysfunction and the strategies that are available, and I know you help couples with this, is important. And as an example, for a woman at a functional level, some radiation therapy to the pelvic area, as I understand it, can cause the vagina to shorten or to narrow, and there are methods to assist women there. But it strikes me for the head and neck, you know, many head and neck people have very serious dry mouth that may be prolonged. They lose teeth and they can't always afford dental care. Some of them have tube feeding for very prolonged periods or even life, and it can mean a tube in your tummy going through the wall of your tummy. So, you know, to me, it's trismus, a difficulty of opening the mouth.
Yeah,
and I think you've had a patient there, a woman had trismus and she wanted to give oral sex to her husband and needed your help. So it's like, I suppose I'm a bit surprised the crisis of the imagination of the cancer world, that they haven't been able to take into account the head and feelings which would effectively take in all cancer patients.
I completely agree with you, but I think we're still in a process of developing levels of comfort in terms of talking about such a private part and intimate part of someone's life and recovery after cancer. So I think in a way, it goes back to what we said at the very beginning of our discussion. If you are feeling embarrassed or awkward then the idea of thinking about that person in terms of their emotional impact and their relational impact and what kind of sexual lifestyle or behaviours they might engage in, again, perhaps based on assumptions that's being made about their age, what kind of relationships they're in, what kind of sexual lifestyle they may have, makes people feel reticent at asking the questions, particularly if they don't know where to refer on to. So then you retreat to the areas of function that you're most familiar with and the ones where you know you've got pathways of rehabilitation for. So in head and neck cancer, of course, you will focus on being able to restore speech, being able to restore appropriate salivary control, offering people tips and tricks in terms of how to work with dry mouth. But you're not thinking about that application at that moment in a sexual context. You're thinking about it more in a communication and in a dietary management context, which is limiting and then prevents you from actually exploring the wider impacts it has on that person's identity and roles in life.
Look, I can understand in the acute phase, the focus is on our survival and those core survival functions. But I was in the Australian context, I know you're in Scotland, but in the Australian context, I returned to my hospital and my cancer team regularly for 5 years. There was plenty of time for someone to say, and how's it going sexually? So I think the acute phase becomes a little bit of an excuse for not opening up the issue. But look, I just want to close because our time is very limited on what you're doing now with Percy Health, this virtual access, because it strikes me that I know this is in the United Kingdom, but it strikes me if there are cancer centres where there either aren't the resources or the cultural willingness to say, yes, sexual health is as important as swallowing and speaking and eating, which I think it is, well, then access to virtual experts, there's a ray of hope there. Just a quick comment on that.
Yeah, I think this is something that has really been one of the few positive things that have come out of the pandemic experience globally, is that we recognise now that we can actually deliver a lot of services through remote video calls and telephone services. And I think I know that in Australia you were well ahead of the curve in doing that because of the geographical distances that people have to travel. But here in the UK, where the distances aren't so great, we were actually really behind in thinking about that. We were really laggards as far as that was concerned. But with the pandemic, we've come to realise that actually one of the ways that we can offer scarce resources more effectively is to look at the development of digital and virtual initiatives. The key thing here is, there's a small body of research, including research that's been carried out certainly in psychological service provision in oncology, where we've looked at equivalence between the delivery of telephone counselling versus or video call counselling versus face-to-face. And although there are certain individuals that we would feel would benefit most from face-to-face contact, I think you can deliver a lot of services virtually. And if you're looking at a service like psychosexual therapy, where the provision of that service and the expertise is not equally spread throughout a country, then offering virtual rehabilitation services offered by a range of allied health professionals can actually help fill in the gaps and increase access to people who need that specialist help, irrespective of where they happen to be living at the time.
Well, Dr. Isabel White, cancer nurse and accredited psychosexual therapist with Percy Health in the United Kingdom, based in Scotland, but it goes across the nation. An absolute pleasure to speak to you, and we will put links to relevant resources with your help at the bottom of the YouTube link that people are probably viewing right now. So this is Deaf Sign Clapping. Thank you very much for joining us.
Thank you very much.